Go into a hospital for a knee surgery. Simple, routine. You've done your research, you've picked a good hospital, a good surgeon. 3 days later, you're not fighting your knee problem anymore. You're fighting for your life. Sepsis, a bloodstream infection you did not have when you walked in. Here's the question nobody prepares you for. Whose fault is that? Is it yours? You didn't do anything wrong. You didn't touch a dirty needle. You didn't eat street food. You were lying in a bed, trusting the people around you. Is it the hospitals? They didn't infect you on purpose. Nobody walked in and injected bacteria into your line. And yet, somewhere between the ventilator, the catheter, the IV line, the hands of a nurse who didn't wash them for the full 20 seconds, somewhere in that chain, something broke. In the United States alone, in 2023, roughly 1 in every 38 hospitalized patients picked up an infection they did not come in with. That's over 500,000 people. And that's just one country with one of the most advanced infection tracking systems on the planet, the CDC's National Healthcare Safety Network. Now scale that globally. Every ICU, every ward, every surgical theater, every day. This isn't a rare freak accident. This is a predictable, trackable, and this is the part that should make you angry, largely preventable phenomenon. It has a name. It has a history. It even, at one point, triggered a legal and financial earthquake that changed how hospitals get paid in America. I've spent my career inside microbiology labs, staring down these organisms under a microscope. And I'm starting a series, this is part 1, where we go deep, textbook deep, CDC deep, into hospital-acquired infections. Today, in the next 25 minutes, you're going to learn the actual story of how doctors discovered hospitals were making people sick and how one man was destroyed for saying it out loud. Why the question, who pays the bill, became a turning point in modern medicine. The real definitions the textbooks use, HAI, nosocomial, healthcare associated, and why the terminology itself had to evolve. The exact chain of 6 links that has to happen every single time for an infection to spread. Where these infections actually come from, including the terrifying fact that sometimes you infect yourself. And the 5 routes of transmission that every nurse, doctor, and microbiologist has to know cold. If you're a nursing student, a medical student, an infection control officer, or just someone who wants to walk into a hospital and understand exactly what's happening around you, do not skip this one. Let's go. How we discovered hospitals were making people sick. Let's rewind. Not 10 years, not 50. Let's go back 180 years to Vienna General Hospital, 1847. There's a young Hungarian obstetrician working there named Ignaz Semmelweis, and he notices something disturbing. His hospital has 2 maternity clinics. In the first clinic, staffed by doctors and medical students, mothers are dying of a raging fever after childbirth at a horrifying rate, sometimes 1 in 10 women. In the second clinic, staffed by midwives, the death rate is a fraction of that. Same hospital, same city, same disease. They called it childbed fever. Wildly different outcomes. Semmelweis becomes obsessed. He rules out overcrowding. He rules out diet. He rules out the position women give birth in. One theory literally blamed women giving birth on their backs versus their sides. Then a colleague of his dies after accidentally cutting himself during an autopsy and shows the exact same symptoms as the dying mothers. That's when it clicks for Semmelweis. The doctors and students in the first clinic were coming straight from the autopsy room, where they'd been dissecting corpses and walking directly to deliver babies, without washing their hands. They were carrying something invisible from the dead to the living. He orders everyone to wash their hands in a chlorinated lime solution before touching a patient. The death rate in that first clinic doesn't just drop, it crashes. from around 18% down to close to 1%. You'd think this makes him a hero, right? A miracle worker? Wrong. The medical establishment of his time ridiculed him. There was no germ theory yet. That was still decades away before Pasteur and Koch would prove microorganisms cause disease. So when Semmelweis said, "Gentlemen, you are carrying death on your own hands," it sounded insane to doctors who considered themselves men of science and gentlemen of status. The idea that they, the healers, were the vector of disease was too uncomfortable to accept. He was pushed out of his job. He had a breakdown. He died in 1865 at just 47 years old in an asylum. Some historians believe from an infected wound, possibly from a beating by asylum guards. The very kind of infection he spent his life trying to prevent. That is the origin story of infection control. Not a clean discovery in a lab, a tragedy. A few years later, across the English Channel, Florence Nightingale is treating soldiers during the Crimean War. She notices soldiers are dying in military hospitals at far higher rates than on the battlefield itself. From disease, not bullets. She becomes a fierce advocate for sanitation, ventilation, and cleanliness. And her statistical work, she was one of the first people to use data visualization in medicine, helps prove that environment and hygiene directly control mortality. Then, Pasteur and Koch give the world germ theory. Joseph Lister pioneers antiseptic surgery, spraying carbolic acid to kill microbes during operations, and surgical mortality plummets. So by the late 1800s, we know hospitals can make you sick. We know hand hygiene works. We know sterile technique works. And yet, fast forward over 100 years to 1999, the U.S. Institute of Medicine publishes a report that shakes the entire medical world. It's called "To Err is Human," and it estimates that medical errors, including hospital-acquired conditions, may be responsible for up to 98,000 deaths a year in American hospitals alone, and tens of billions of dollars in costs. 98,000 deaths. Roughly a plane crash's worth of people every single day, dying not from the disease they came in with, but from the care itself. That report is the moment infection prevention stops being a nice-to-have quality initiative and becomes a national patient safety emergency. Who pays the bill? The question that changed healthcare. Now here's where it gets interesting, and honestly, a little bit uncomfortable. Picture this. You come into a hospital for a hip replacement. Your insurance is billed for the surgery, the recovery, the physiotherapy. Standard cost, roughly predictable. But now imagine, 3 days after your surgery, you develop a catheter-associated urinary tract infection because the urinary catheter that was inserted for your convenience during surgery wasn't removed on time or wasn't handled with sterile technique. Now you need extra antibiotics, extra lab tests, extra days in the hospital, maybe an ICU transfer if things go badly. Who pays for that extra care? For most of medical history, the answer was simple and, frankly, a little unfair. The patient's insurance did. Automatically. Hospitals were reimbursed for the complications of care exactly the same way they were reimbursed for the original care. More complications, in a purely financial sense, meant more billing. Think about what kind of incentive that creates. There was, structurally, almost no direct financial penalty for a hospital if a patient acquired a preventable infection. The extra ICU days, the extra medication, the extra dialysis if the kidneys were damaged by sepsis. Insurance and government payers picked up the tab, no separate questions asked. Patient safety advocates started asking the obvious moral question. The patient did not come to the hospital with this new infection. They came with a hip problem, or a heart problem, or they came to deliver a baby. The infection was not the disease of admission. It was acquired inside the walls of the very institution meant to heal them. So why should the patient's insurance, and ultimately the patient and taxpayers, absorb 100% of that cost, as if it were just bad luck, like a natural disaster, instead of, in many cases, a preventable systems failure? This question builds for years, fueled by that 1999 Institute of Medicine report, and by growing research showing that a large share of these infections are preventable with proper protocol. Hand hygiene, sterile catheter insertion, timely catheter removal, ventilator care bundles. And in the United States, this question finally gets a policy answer. In 2005, the Deficit Reduction Act directs Medicare, the government health insurance program, to start identifying reasonably preventable hospital-acquired conditions. Then, starting October, wrong site surgery, foreign object left in a patient after surgery, and, directly relevant to us, specific hospital-acquired infections like catheter-associated urinary tract infections and certain surgical site infections after particular procedures. Suddenly, infection prevention wasn't just an ethical or clinical priority. It became a financial survival issue for hospitals. Infection control committees, which used to be seen almost as an administrative afterthought, became central to a hospital's bottom line. Hand hygiene compliance, catheter care bundles, surgical checklists. These stopped being best practice suggestions and became the difference between a hospital staying profitable or bleeding money. This is genuinely one of the most important policy shifts in the entire history of patient safety, because it aligned the hospital's financial incentive with the patient's actual well-being for the very first time at this scale. So when we talk about infection prevention in this series, I want you to remember, this isn't just microbiology. It's history, it's ethics, it's economics. All three collide at the bedside. Now, let's get into the science. Let's define exactly what we're talking about. Definitions. What exactly is an HAI? You'll hear three terms used almost interchangeably, and honestly, that interchangeability itself has a history. Term 1. Nosocomial infection. This is the oldest term. It comes from the Greek word nosokomeion, meaning hospital. A nosocomial infection is classically defined as an infection that was neither present nor incubating at the time of admission, and that develops during the course of hospitalization, typically appearing 48 to 72 hours after admission, or sometimes defined as appearing within a set window after discharge or after a specific procedure like surgery. Term 2. Hospital-acquired infection, or HAI. Functionally, this is the same idea, but the phrasing is more direct and more commonly used today, especially in surveillance systems like the CDC's NHSN. The core definition: a localized or systemic condition resulting from an adverse reaction to the presence of an infectious agent or its toxins that was not present at the time of admission to the healthcare facility. Term 3. Healthcare-associated infection. This is the modern, broader term, and the shift to this language matters. Why? Because medicine doesn't happen only inside hospital walls anymore. Patients get infections from outpatient surgical centers, dialysis clinics, long-term care and nursing facilities, home healthcare visits with IV lines, even ambulatory infusion centers. Nosocomial and hospital-acquired both imply the hospital is the only setting, but healthcare-associated acknowledges that the entire healthcare system, wherever care is delivered, can be the source. For this series, I'll mostly use HAI in line with CDC terminology, but I want you to understand, when you see nosocomial in an older textbook and healthcare-associated in a newer CDC document, they're pointing at the same core phenomenon, just with the terminology maturing as our understanding of where healthcare happens has expanded. One more critical definitional detail, and this trips up a lot of nursing and medical students in exams. An infection is only classified as an HAI if there's no evidence the infection was present or incubating at the time of admission. If a patient comes in already showing early signs of pneumonia and it's confirmed within the incubation window, that is a community-acquired infection, not hospital-acquired, even though the diagnosis was made inside the hospital. The timing and origin is what defines the category, not simply where the diagnosis happened. The numbers. How big is this problem, really? Let's talk epidemiology, because numbers make this real. The CDC runs periodic point prevalence surveys across hundreds of acute care hospitals to track exactly how common HAIs are. Here's the trend, and it actually tells a hopeful story layered on top of a sobering one. In 2011, roughly 4.0% of hospitalized patients had at least one HAI on any given survey day. In 2015, that number dropped to 3.2%, about 1 in every 31 patients. In the most recent large survey, conducted in 2023 and published in the New England Journal of Medicine, that number dropped again to 2.6%, or roughly 1 in every 38 hospitalized patients. That's a 27% reduction in the likelihood of acquiring an HAI compared to 2015. Now, that is progress. Real, measurable, meaningful progress built on decades of the infection control work we're about to break down in this series.
But here's the number that should stop you in your tracks. Even with that improvement, the CDC estimated there was still roughly 518,000 hospital-acquired infections in U.S. acute care hospitals in that single survey year. 500,000 in one country, in hospitals that are, relatively speaking, among the best resourced in the world. And when researchers broke down what kind of infections these were, here's the distribution. Pneumonia was the single most common category, at roughly 26% of cases. Surgical site infections came next, at about 21%. Gastrointestinal infections, largely driven by an organism called Clostridioides difficile, which we'll cover in depth in this series, at around 14 to 15%. Bloodstream infections, around 12%. Urinary tract infections, around 9%. And the rest split across other types. Here's a detail that genuinely surprised infection control experts. About 61% of these infections were not linked to an invasive device or a procedure at all. We tend to picture HAIs as something that only happens because of a catheter or a ventilator, a device problem. But the majority weren't device-related. That tells us something important, which we'll dig into across this series. HAIs are not just a device problem. They're a systems and behavior problem. Hand hygiene, environmental cleaning, antibiotic stewardship, staff-to-patient ratios, and basic technique every single hour of every single day. Globally, if we zoom out beyond the US, a major European point prevalence survey across 28 countries found that on any given day, roughly 6.5% of patients in acute care hospitals had at least one HAI, and estimated close to 9 million HAI episodes per year across acute and long-term care combined in Europe alone. Different regions, different baseline numbers, but the same underlying truth. This is a massive, ongoing, global patient safety burden. So now you understand the scale. Let's understand the mechanism, because to prevent something, you first have to understand exactly how it happens. The chain of infection, the 6 links that must all connect. This is, without exaggeration, one of the single most important frameworks in all of infection control. If you remember nothing else from this video, remember this chain. Because every single prevention strategy we will ever discuss in this series exists to break one specific link in it. Link 1. The infectious agent. This is the pathogen itself: bacteria, viruses, fungi, or parasites. Think Staphylococcus aureus, E. coli, Klebsiella pneumoniae, Pseudomonas aeruginosa, Clostridioides difficile, or drug-resistant organisms like MRSA and CRE, which we'll cover in a dedicated future episode. Its ability to cause disease depends on factors like how many organisms are present, how virulent, how aggressive the strain is, and how resistant it is to antibiotics. Link 2. The reservoir. This is where the organism lives and multiplies before it attacks. It could be a human, a patient, a healthcare worker who's an asymptomatic carrier, even a visitor. It could be equipment, ventilator tubing, a stethoscope, a blood pressure cuff. It could be the environment, bed rails, sinks, curtains, even flower water in a patient's room. Link 3. The portal of exit. How does the organism actually leave the reservoir? Through respiratory secretions when someone coughs, through the gastrointestinal tract via stool, through blood via a needle or an open wound, through the skin. Link 4. The mode of transmission. This is how the organism physically travels from the reservoir to a new host. And this is such a critical topic that we're going to spend our next full segment breaking down every route in detail. Link 5. The portal of entry. Once the organism reaches a new potential host, it needs a way in. This could be a break in the skin, a surgical incision, an IV insertion site. It could be mucous membranes. It could be the respiratory tract via inhalation. It could be a urinary catheter providing a direct highway into the bladder. Link 6. The susceptible host. And finally, does this new person's body actually allow the infection to take hold? A patient with a weakened immune system, from chemotherapy, from diabetes, from extremes of age, from malnutrition, from an existing critical illness, is far more susceptible than a healthy adult. This is exactly why ICUs, burn units, oncology wards, and neonatal units are considered high-risk areas. The patients there sit at the most vulnerable end of this link. Now here's the concept I need you to truly internalize. This is called a chain because it only takes one broken link to stop the entire infection from happening. You don't need to defeat the bacteria itself to prevent the disease. You just need to break one connection. Remove the reservoir, clean the equipment, block the portal of exit, cover a cough, interrupt the mode of transmission, hand hygiene, protect the portal of entry, proper aseptic catheter insertion, or protect the host. Vaccination, nutrition, good glycemic control. This is why hand hygiene alone, something so simple, so unglamorous, is consistently ranked by the World Health Organization and CDC as the single most effective intervention in all of infection control. It attacks the chain at its most vulnerable, most frequently used link, transmission, over and over, hundreds of times a day, in every single patient interaction. Where do these infections actually come from? Let's talk source, because there's a distinction here that genuinely surprises people outside of medicine, and honestly, surprises some students too.
The gut flora houses trillions of bacteria. A breach in the intestinal barrier occurs.
Endogenous
bacteria
infection,
squeeze through the tight junctions. They enter
This
the
is when the
bloodstream,
organism
causing systemic
the
infection.
was already living on or inside the patient's own body, usually as part of their normal, harmless microbial flora, and it moves to a site where it becomes harmful. The classic example? A patient's own gut bacteria, like E. coli, normally lives quietly in the intestines. But during a surgery, or through a urinary catheter, that same organism migrates to the bladder or the bloodstream, a place it was never meant to be, and now it's a life-threatening infection. This is a genuinely important concept because it means the infection can happen even if every single external hygiene protocol was followed perfectly. The threat was inside the patient the entire time, waiting for an opportunity created by a medical device or a weakened immune system. Exogenous infection, cross-infection, or environmental infection. This is the one most people picture when they think hospital infection. The organism comes from outside the patient. This could be cross-infection, transmitted from another patient, or from a healthcare worker's hands, or from a visitor. Or it could be environmental, picked up from contaminated equipment, hospital surfaces, water systems, or even the air handling system in an operating theater. Here's why this distinction actually matters practically, not just academically. The prevention strategy is completely different depending on the source. If an infection is endogenous, your prevention strategy focuses on things like minimizing invasive device use, proper antiseptic skin preparation before inserting a line, and antibiotic prophylaxis before surgery. If it's exogenous, your prevention strategy shifts to hand hygiene between patients, environmental cleaning protocols, and isolation precautions. That CDC statistic I mentioned earlier, that 61% of HAIs weren't linked to a device or procedure, should make you think harder about both categories, not just assume every infection came from a dirty surface. The 5 routes: how infections actually travel. This is link 4 of the chain, expanded, the modes of transmission. Every infection control policy you'll ever see in a hospital, isolation signs on doors, PPE requirements, negative pressure rooms, exists because of these 5 categories.
1. Contact transmission, the most common route in healthcare. This splits into 2 types. Direct contact is physical, body surface to body surface transfer. A healthcare worker's bare hands touching a patient's open wound, for instance. Indirect contact involves an intermediate object, what we call a fomite, like a contaminated stethoscope, blood pressure cuff, bed rail, or even a shared pen, transferring the organism from one surface to a new host. This is exactly why we push hand hygiene before and after every patient contact, and why equipment cleaning between patients is non-negotiable. 2. Droplet transmission. When someone coughs, sneezes, talks, or during procedures like suctioning, they release respiratory droplets. These are relatively large particles that don't travel far, typically settling within about 3 to 6 feet, and don't stay suspended in the air for long. Organisms like influenza and certain bacterial meningitis strains spread this way. This is why droplet precautions typically involve a surgical mask and maintaining physical distance. 3. Airborne transmission. This is different and more concerning because it involves much smaller particles, droplet nuclei, that can remain suspended in the air for extended periods and travel much further distances, even through air currents and ventilation systems. Tuberculosis is the textbook example. This is why airborne precautions require specialized N95 respirators, not just surgical masks, and often require negative pressure isolation rooms that prevent contaminated air from flowing out into hallways. 4. Vehicle-borne transmission. This is transmission through a contaminated common source, contaminated food, contaminated water systems within the hospital, contaminated blood products, or contaminated intravenous drugs and fluids. This is why sterile compounding of IV medications and rigorous blood bank screening protocols exist. A single contaminated batch can infect multiple patients simultaneously, which is part of what makes vehicle-borne outbreaks so dangerous. 5. Vector-borne transmission. The least common in most hospital settings, but still relevant. Transmission via insects or animals, like mosquitoes or flies, that mechanically or biologically carry an organism from one source to a new host. This becomes more clinically relevant in hospitals located in regions with high vector-borne disease burden, or hospitals with inadequate pest control. Here's the exam critical point, and the point that matters just as much in real clinical practice. Many organisms don't stick to just one route. Some pathogens can spread through multiple mechanisms simultaneously, which is exactly why standard precautions, treating every patient's blood and body fluids as potentially infectious every single time, regardless of diagnosis, form the baseline of infection control, layered underneath any additional transmission-specific precautions. Quick recap. Let's lock this in before we close. In the last 25 minutes, you learned: Semmelweis discovered hand hygiene could save lives and was destroyed for it
because germ theory didn't exist yet to back him up. The 1999 To Err is Human report exposed the true scale of preventable harm in hospitals, and by 2008, that led CMS to stop paying hospitals extra for treating conditions patients acquired inside their walls, flipping the financial incentive toward prevention. HAI, nosocomial infection, and healthcare-associated infection all describe the same core phenomenon, an infection absent at admission, with the terminology evolving as healthcare delivery expanded beyond hospital walls. As of the CDC's most recent data, roughly 1 in 38 hospitalized patients has an HAI on any given day, real progress from 1 in 25 a decade ago, but still over 500,000 cases a year in the U.S. alone. Every infection requires all 6 links of the chain of infection to connect, and breaking even one link stops it. Infections come from inside the patient's own body, endogenous, or from outside sources, exogenous, and they travel via contact, droplet, airborne, vehicle-borne, or vector-borne routes. Now here's the thing. Everything we covered today is the foundation. It's the why and the how it spreads. But in part 2 of this series, we're going deep into the specific types of HAIs that make up that 500,000 number: catheter-associated UTIs, surgical site infections, ventilator-associated pneumonia, central line bloodstream infections, the exact organisms responsible, and the CDC and WHO protocols hospitals actually use to stop them before they start. If this video actually taught you something, if that Semmelweis story hit you the way it hit me the first time I read it, do 3 things right now before you scroll away. Hit subscribe and tap that bell, because this series is going to be one of the most complete textbook and CDC